All right, well, thank you everyone for joining us, and welcome to the Cancer Research Institute's webinar series, Breakthroughs in Cancer Immunotherapy. Today's date is Thursday, November 20th, 2014, and the title of today's webinar is Immunotherapy for Pancreatic Cancer. My name is Brian Brewer. That's a picture of me before I grew the beard. I'm Director of Marketing and Communications at the Cancer Research Institute. Cancer Research Institute is the world's only nonprofit organization dedicated exclusively to harnessing the power of the immune system to conquer all types of cancer. We fund scientists globally whose work has led to significant breakthroughs in treating cancer with immunotherapy. Over the next 45 minutes, you'll hear firsthand from an expert in immunotherapy about exciting advances in the treatment of pancreatic cancer, thanks to these breakthroughs. Of course, you may also be aware that November is National Pancreatic Cancer Awareness Month, so this is a very timely webinar. After a 25-minute presentation from our speaker, we will open the discussion to questions submitted by you. You can submit a question at any time throughout the webinar by typing in the Q&A box on your screen. I will try to get to those questions at the end of Dr. Beatty's presentation. Today's webinar is being recorded and will be made available on our website and our YouTube channel after today's presentation. Now it's my pleasure to welcome today's speaker. Dr. Gregory Beatty is an assistant professor of medicine at the Perelman School of Medicine at the University of Pennsylvania and in the Division of Hematology Oncology within the Abramson Cancer Center at the Hospital of the University of Pennsylvania. His research interest is in developing novel immunotherapies for the treatment of gastrointestinal cancers, including pancreatic cancer. He has developed a research platform within his laboratory that uses mouse models of cancer to study the role of the immune system in cancer and to screen novel immunotherapeutic strategies, including cell and gene therapies for the treatment of cancer. We are honored that he could join us today. Dr. Beatty, welcome.
Thank you, Brian. It is really a great pleasure to be invited to participate in this amazing initiative of the Cancer Research Institute. I've been very fortunate over the past couple of years to have had the opportunity to be a part of this research effort that is supported by the CRI, who really has had this vision of bringing forth novel treatment options for patients. This effort that has been invested by CRI into understanding the details of how the immune system recognizes cancer is really transforming into substantial advances to treat a wide variety of tumors of various types. Today I will focus on pancreatic cancer. I'm trained as a medical oncologist and have invested my research and clinical effort into studying new immune-based treatment approaches for pancreatic cancer. I currently lead several clinical trials investigating immunotherapy for this disease and only see patients who are enrolled in phase 1 clinical studies. I also lead a discovery laboratory that is investigating how to redirect the immune system to recognize and control pancreatic cancer, and we'll talk about some of this work today. The clinical pancreatic cancer is illustrated on this particular slide. Compared to all other malignancies, pancreatic cancer has been one of the most difficult cancers to treat. Even when diagnosed early, what one can see is that the vast majority of patients will relapse. And we believe that this is due, at least in part, to the early spread of pancreatic cancer to distant organs, which may not be appreciated in many cases on initial diagnosis. It's also been suggested that pancreatic cancer develops over many years, and as a result, by the time a patient is diagnosed, their disease is usually quite advanced. So in fact, most patients who are diagnosed with pancreatic cancer will have evidence of disease spread, in other words, metastasis, at the time of their diagnosis. This is also due to an insidious clinical presentation of this disease, which often presents with unexplained weight loss, fatigue, nondescript abdominal pain and/or back pain. And in some cases, the disease presents with a sudden yellowing of the skin and eyes, in other words, jaundice, which is due to impingement of the cancer on the biliary system. Pancreatic cancer is well recognized for its spread to distant organs. with the most common site of metastasis being the liver, as well as the lymph nodes, and then followed by the peritoneum, and then the lung. Spread of pancreatic cancer to the peritoneum is commonly associated with the accumulation of fluid called ascites. Under a microscope, pancreatic cancer has several distinct appearances, which are dependent on their subtype. The most common form of pancreatic cancer is pancreatic ductal adenocarcinoma, and is associated with what can be seen here and is called a desmoplastic reaction. This reaction is in essence an extensive fibrosis that surrounds these islands of tumor cells and involves an inflammatory immune response as well. The second most common form of pancreatic cancer is called pancreatic neuroendocrine tumor. Its prognosis is quite different from what one sees with pancreatic cancer, and certainly under the microscope it also appears quite different. Now, there are also several other rare forms of pancreatic cancer, but for this talk I will focus largely on pancreatic ductal adenocarcinoma, in particular pancreas cancer that has spread or is surgically unresectable, given that this is the most common form of presentation for this particular cancer. So over the past 20 years, the medical oncology community has invested a strong effort in trying to develop novel treatment approaches for treating metastatic pancreatic cancer. Some of these are depicted on this slide, a summary of this, with gemcitabine being one of the first chemotherapeutic regimens that was instituted back in 1997 based on its ability to provide clinical benefits, in other words, pain control and improved symptoms to some patients with pancreatic cancer. Over the last couple of years, what one can see is that there have been some newer regimens called FOLFIRINOX, which is a combination of 4 drugs, as well as gemcitabine and nab-paclitaxel, which is also called Abraxane. And with these newer drug regimens, one can see that we're beginning to see improvements and disease control, but it's clear that we need to do better. And this really, I believe, begins with understanding what are the barriers to therapy in pancreatic cancer. So I already mentioned that pancreatic cancer, ductal adenocarcinoma, is quite unique because of this extensive fibrosis that surrounds cancer cells. This fibrosis, along with a poor blood supply, has been found to limit the delivery of drugs delivery of drugs to cancer cells. And so this is one mechanism by which pancreatic cancer is resistant to our current standard therapies. Other mechanisms of resistance include the genetic instability of this disease and the heterogeneous nature of pancreatic cancer. Pancreatic cancer is really made up of, I would say, many pancreatic cancers, with individual cancer lesions having the potential to be quite different from each other. This means that with treatment, some lesions may actually respond to therapy, but at the same time others may not. In addition, treatments may select for tumors that are ultimately resistant to the current therapy. As a result, there's a strong efforts now towards understanding these treatment resistance mechanisms. And certainly the fibrosis that's seen here is one of these. This fibrotic region that I'm pointing out is an extensive area of research that looks at what we call this as the stroma, this pink hue or pink area here that separates these islands of tumor cells. It's quite amazing, I would say, to think that this stromal compartment can represent upwards of 50% of pancreatic cancer. Now within here there are certainly blood vessels, as well as an extensive infiltration of white blood cells, which represent the immune system. These immune cells, which here are marked by a protein called CD45, which is leukocyte common antigen, can be seen here marked in brown in this section of a human pancreatic cancer tumor. And what one can see from this is that amongst these malignant cells, which are outlined here, these immune cells become in close contact with pancreatic cancer. This is in really stark contrast to the ability of drugs to enter cancer lesions, and in part this explains, really I would say, some of the excitement around immunotherapy for pancreatic cancer, because of the unique ability of the immune system to seek out and find cancer cells. And certainly the immune system is already a part of pancreatic cancer, so are there ways in which we can harness this immune response that's already exists? Now, the role of the immune system in pancreatic cancer, though, I would say is largely believed to, in general, promote tumor survival and cancer cell spread. And in fact, for the most part, there's really an unequal representation of the immune system within this microenvironment that surrounds cancer cells, with the vast majority of these cells being represented by a population of immune cells called macrophages. In contrast, there's really quite a scarcity of effector T cells within tumors. And when these T cells are observed, they usually appear to be confined to tumor margins, so the edges of tumors. And it's not clear at this time whether these T cells that one does see sometimes around pancreatic tumors are related to their specificity against the tumor, or whether or not they are associated with pancreatitis, inflammation within the pancreas that can often accompany this disease. In addition, I would say that regulatory T cells, which act to suppress the immune system and immune responses, are more commonly seen in surrounding pancreatic lesions than effector T cells, which can potentially have anti-tumor properties. In the next several slides, what I will do is address the potential role of macrophages and T cells and their potential value and mediating anti-tumor immune responses, and some of the ongoing strategies that are being directed at trying to harness the potential of these two distinct cell types for treating pancreatic cancer. So macrophages have recently received quite a bit of attention within the scientific community, for sure, for cancer, particularly because of their role in promoting cancer and cancer spread. However, I think it's important to note that the phenotype and function of macrophages is pliable, such that they can take on really a spectrum of activities ranging from tumor promoting, so pro-tumor, to tumor suppressive, in other words, anti-tumor. For example, we know that macrophages, from research in the laboratory, that they can support the formation of blood vessels and thus potentially foster tumor growth, that they can support tumor proliferation and survival, that they can inhibit the ability of T cells to recognize and attack cancer cells, and lastly, that they can also be very important and critical players in facilitating the spread of cancer to distant organs. So, what are the approaches that are under investigation to deal with macrophages then in cancer, particularly given their dual potential to be either tumor promoting or tumor suppressive? This slide depicts three potential ways to address macrophages in cancer. The first is to simply attempt to deplete macrophages from around tumors, or to alternatively block their recruitment to tumor lesions. These therapeutic approaches that are listed below here have been borne out in studies in the laboratory and highlight three representative examples of strategies to block macrophage recruitment using CCL2 inhibitors, or alternatively to deplete macrophages. The second approach that's being explored in early phase clinical studies is also to try to inhibit particular activities that macrophages might engage in when they come in contact with tumor cells. And these approaches are designed to really remove some of the tumor-promoting behaviors of macrophages. And some of these strategies are listed below here. The last approach is really to try to harness the recruitment of macrophages to tumors. These cells are naturally trophic to pancreatic cancer, and so approaches that can redirect their behavior from tumor-promoting to tumor-suppressing may be particularly efficacious. To illustrate this, what I want to do is to share one study that was conducted here at the University of Pennsylvania and illustrates the potential of redirecting macrophages with tumor suppressive properties. So this was a phase 1 clinical study conducted in patients with surgically unresectable pancreatic cancer. 90% of patients had metastatic disease at the time of their diagnosis, and all patients were treated in the first-line setting, which simply means that this was their first treatment for pancreatic cancer. At the time of this particular study, gemcitabine was the mainstay of treatment for pancreatic cancer, and so patients on this particular clinical trial received gemcitabine as standard of care therapy. And then they also received an investigational drug. This is an agonist anti-CD40 antibody. It's a fully human IgG2 monoclonal antibody with potent and selective agonist activity and minimal activation of complement for Fc receptor binding. This drug was administered 48 hours after the first dose of gemcitabine and was administered with each month of treatment. Overall, patients tolerated this treatment quite well. Some patients experienced what we call a cytokine release syndrome, in which they developed chills and fevers. In general, this lasted for about 30 minutes to an hour and was easily manageable within the outpatient clinic. Patients also underwent CT staging scans performed at baseline and after every 2 months of therapy. 21 patients were treated on this study. 5 patients developed a partial response, which means that at least a 30% decrease in the sum of the longest dimensions of target lesions was seen in these patients, which is promising compared to what one would expect with gemcitabine chemotherapy by itself, where 1 or 2 patients may have responded. One such example of a patient responding to therapy on this trial is shown here. This patient at baseline had a lesion in the head of the pancreas, which is shown here with the yellow arrows, as well as a large liver metastasis and a second liver metastasis indicated with the yellow arrows. After 3 months of treatment, this patient experienced a partial response in which there was an approximate 50% decrease in the size of the head of the pancreas, shown here in terms of the longest diameter. The liver metastasis lesion completely disappeared, and the second liver metastasis lesion shrunk by about 50%. This lesion, which is indicated by the arrow, was biopsied and interestingly revealed an absence of tumor cells and a predominance of macrophages. We went on to investigate this finding further in the laboratory and determined using an animal model that I will share with you in the next couple of slides that this treatment effect was likely to be attributed to the capacity of this agonist CD40 antibody to redirect macrophages with tumor suppressive properties. So this is the animal model that I'm referring to. It's depicted here. We and others have been using these types of animal models as well as other similar models to guide the translation of new treatments from the laboratory to the clinic. This is possible because these mice can be engineered to spontaneously develop pancreatic cancer that recapitulates many of the salient features that we see in human cancer. This model incorporates 2 mutations that are commonly observed to be mutated in human pancreatic cancer, specifically an activating mutation in the KRAS oncogene and a dominant negative mutation in the p53 tumor suppressor gene. These 2 mutations are specifically targeted to the mouse pancreas using Crelox technology, and the resultant mice will spontaneously develop pancreatic cancer with 100% penetrance meaning that all mice will develop pancreatic cancer. Now, cancer development in this model mirrors that which we commonly see in human pancreatic cancer, which is shown in these slides below. There's this early stage, which we call pancreatic intraepithelial neoplasia, in which these early lesions will progress on to invasive pancreatic cancer. We even see spread of the disease to distant organs, which in this case is showing a metastasis to the liver. Under the microscope, the cancer is indistinguishable from human pancreatic cancer. And so this model has become an attractive approach for testing therapeutics prior to their investigation in patients. It is felt that this approach will also potentially lead to more efficient means to screen novel compounds and treatment strategies. So using this particular model, we investigated in the laboratory the mechanism by which macrophages might be responding to this agonist CD40 antibody and facilitating tumor regressions in patients. We found that the treatment with a CD40 antibody rapidly induced the infiltration of macrophages into tumors identified in these mice that developed spontaneous pancreatic cancer, that these macrophages acquired the capacity to kill tumor cells, and that they facilitated, with which I'm showing here, the depletion of components of the extracellular matrix of this stroma. And that's seen in terms of these blue extracellular matrix fibers amongst the red, which are identifying cells, in particular tumor cells. And after treatment with an agonist CD40 antibody, one can see that these extracellular matrix fibers are largely degraded. They disappear. In addition, from this slide, there also appears to be a decrease in tumor cell content in the tumors, consistent with the findings that we saw in the patient biopsy, with really a decrease in the number of viable tumor cells and a predominance of macrophages. However, if we deplete macrophages prior to treatment with this agonist CD40 antibody, what we find is that this treatment effect is lost, and the impact on the extracellular matrix fibers is lost, and the ability of this antibody to induce tumor regression in the mice is also lost. As a result of this type of finding, this, I would say, has really spurred a strong interest in potential ways to redirect macrophages with tumor suppressive properties. It also raises the question, though, of what is the role of the stroma that surrounds tumors in pancreatic cancer. Is it supportive? Is the stroma supportive of pancreatic cancer, or does it act to restrain cancer cell spread and growth? And certainly ongoing clinical studies are investigating strategies to deplete this stroma in order to facilitate better drug delivery, given the fact that the stromal compartment can be a barrier to the diffusion of drugs. However, we are also learning that the role of the stroma in pancreatic cancer is not necessarily so simple. This is highlighted in these two studies that were reported in a high-profile journal over the summer, demonstrating the potential role for the stroma in restraining rather than supporting pancreatic cancer. In general, these two studies found that depletion of factors responsible for fibrosis within the stroma that surrounds pancreatic cancer, so if you deplete certain factors, such as fibroblasts or silent hedgehog, that this can lead to an increased tumor growth in animal models. This is thought to be due to the release of factors that are ordinarily sequestered in the stroma, but are released when the stroma is depleted, such as vascular endothelial growth factor, and that these factors can drive blood vessel formation and therefore support the nourishment of the cancer. From this finding, I would say that approaches used to target the stroma in pancreatic cancer will need to be considered carefully. There are certainly likely to be strategies aimed at manipulating the stroma that could hasten tumor growth and spread, but I think that in the right context, approaches such as therapies that target macrophages and the CD40 pathway, and elements that approaches that act to redirect elements of the stroma may be quite beneficial for impacting pancreatic cancer growth and even its spread. So I want to return to this initial slide that I shared, because I talked a little bit now about macrophages and their potential role and their interaction with the stroma. And I want to now discuss the potential benefit that may come from targeting T cells, and which are rarely observed to interact with pancreatic cancer cells in patients. So how do we bring these T cells and their therapeutic potential to pancreatic cancer? So T cells are particularly attractive targets for cancer therapy, particularly given these four fundamental laws of the immune system, which are outlined on this slide. First, T cells have the potential to recognize a near unlimited array of antigens. This means that a T cell has the potential to distinguish between cancer and normal cells. This precision is unlike what one would see with chemotherapy and many other targeted therapies, which inevitably can have side effects to their impact on normal tissues. T cells are usually quite effective, though, at seeking out and responding to injury. And so this surveillance component is a key feature of T cells and their capacity to be potent cancer-fighting cells. In order to control their activity, though, the immune system has devised ways in which to suppress the function of T cells. And this is, in essence, designed to control the ability of T cells to distinguish between self and non-self. In fact, cancer cells exploits many of these mechanisms of tolerance as a means of evading immune recognition and elimination by T cells. Now, a real advantage, though, to T cells and even over macrophages is that their ability to remember. So this memory component of T cells is key. And so unlike chemotherapy and targeted therapies, which must be repeatedly administered, T cells can persist in the body for decades and remember their targets, and so they can maintain a basal level of anti-tumor immunity. To harness the potential of T cells for the treatment of cancer really, I would say, involves understanding or having the knowledge of how T cells become activated and mediate anti-tumor activity. This is depicted in this slide and illustrates the cancer immunity cycle, in which a cancer cell will release proteins which can alert T cells to their identity as malignant cells. These proteins are then taken up by cells such as macrophages and dendritic cells and presented to T cells to prime and activate them. These T cells must then traffic to tumors, infiltrate those tumors, and then have the ability to recognize cancer cells and kill them. To restore this cycle, multiple different immune-based therapies are currently under investigation. Some of those are highlighted here. And in the next couple of slides, what I'll do is share some of the knowledge that we've gained from using these approaches, particularly in pancreatic cancer to date. I've already talked a little bit about CD40, and what I'll just share is a little bit more about some of these immune checkpoint molecules. So I mentioned that tolerance is a key feature of T cell biology. This is designed, in essence, to prevent T cells from attacking normal tissue. However, cancer cells also have the capacity to induce tolerance of T cells. And they do this in part by engaging receptors on T cells, such as PD-1 and CTLA-4, that will instruct these T cells to become inactive or inert. Two examples of these are PD-1 and C2A4. These are called immune checkpoint molecules and have received significant attention in the medical community, particularly for their ability to induce tumor regressions in some cancers such as melanoma. But as well as we're now seeing effects in lung cancer and renal cancer and even bladder cancer. However, what is highlighted on this slide is that by themselves, in terms of their ability to mediate an impact in locally advanced metastatic pancreatic cancer, and combination with chemotherapy in metastatic pancreatic cancer, and as single agents in metastatic pancreatic cancer, that these therapies by and large have not produced a significant impact to date. Now that's not to say that they won't have the potential to be efficacious strategies in the future. I think what we're learning is that there's, going back to the cancer immunity cycle, that there are several components that may need to be restored in that particular cycle for immune-based therapies to work in pancreatic cancer. And this may be due to the fact that in order for T cells to be efficacious against cancer, they must first be primed and activated. And since it's uncommon to actually find extensive amounts of T cells in pancreatic cancer, it may actually be necessary to first use a vaccine to boost tumor-specific T cells. And this approach is an early study using this approach is described here, in which ipilimumab, which is an antibody against C2A4, which I showed on the previous slide, is combined with or without a vaccine. GVAX here is an irradiated allogeneic whole tumor cell vaccine that's engineered to express GM-CSF, which is a cytokine that's designed to promote the development of antigen-specific T cells by fostering antigen presentation. And in this slide, what is shown is an example of a patient who received vaccine therapy in combination with ipilimumab. And overall, I'd say that this combination led to what one could call very promising clinical responses in some patients with pancreatic cancer. One example here shown of a lung lesion, which at baseline one can see this highlighted with the yellow circle. After 7 weeks of treatment, the lesion gets a little bit bigger. And this is a finding that we've been seeing with T-cell-based therapies in cancer in general. Because if you follow this lesion out further, what you find is the lesion now is actually shrinking. Overall, I would say this is an encouraging finding and suggestive of the potential of combining various immunotherapeutic approaches together for the treatment of pancreatic cancer. This increase in size is believed to be due to the recruitment of T cells as well as other inflammatory immune cells that help to mediate this tumor regression. And it just takes time for T cell-based immune therapies to work in some cases in cancer. Another approach that has gained particular attention, particularly because of promising results in patients with leukemia, involves strategies to engineer T cells with anti-tumor properties. This approach, which involves the engineering of a patient's own T cells with a chimeric antigen receptor that can recognize the cancer cell because of a protein that's present on the surface of that cancer cell, is fused with a signaling domain that allows for this T cell to become activated when the receptor engages its target. This approach involves collecting a patient's white blood cells, or their own immune cells, from which is very much like giving blood, in a process called leukapheresis. These T cells are then isolated from the white blood cells that are collected, and they're engineered then to express this chimeric antigen receptor. And one of the most common approaches is to use either retroviruses or lentiviral viruses to insert this chimeric antigen receptor into the gene genome of the T cell. These T cells are then expanded in culture in the laboratory, and then they are ultimately reinfused back into the patient. Studies that are addressing this particular approach, there are a couple of studies across the country now that are looking at chimeric antigen receptor modified T cells for the treatment of pancreatic cancer. I'd say that at this point it's too early to comment about the efficacy and whether or not additional treatment strategies will need to be combined with in pancreatic cancer. I think as a scientific community, we certainly understand that the microenvironment that surrounds solid cancers, as opposed to those that surround liquid cancers, such as leukemias, are quite distinct. In our animal models, we've also been learning that this unique microenvironment can have an impact on the ability of T cells to impact cancer, and that combination therapies may eventually be needed in order to bring forth T cell based therapies in pancreatic cancer. Overall, I would say that this is a very exciting time for immunotherapy in cancer, and also in pancreatic cancer. Many of the studies that are now underway, in which this was an article published in the Journal of Clinical Oncology just last year, illustrating the distribution of clinical trials, early phase 1 studies that are phase 2 and phase 3 studies that are underway for pancreatic cancer, and what is certainly well represented at this point are immune-based therapies, and there are many more that are coming out each year, and so I think that there are going to be more and more opportunities for patients to be able to seek out and physicians to be able to identify immunotherapy approaches for their patients. At this time, though, many of these studies are early, and so opportunities are not abundant, but I'm hopeful that this will change in the future. The approaches that are being exploited overall for immunotherapy in pancreatic cancer are listed on this particular slide. I highlighted many of these in the talk. Vaccines using whole tumor cell vaccines such as GVAX. Cyclophosphamide is a form of chemotherapy that's been largely used to eliminate the ability of regulatory T cells to inhibit T cell based immunotherapies. There's also a vaccine approach called hyperacute pancreas vaccine, which is being explored particularly within the adjuvant setting. So patients who have undergone surgery for their cancer and are receiving adjuvant standard of care therapy can also, in a clinical trial setting, receive this vaccine approach, which may have promise. There are also combination approaches that are being explored in terms of GVAX and a listeria-based vaccine. This is a bacteria that's highly attenuated and engineered to express a antigen that is expressed by cancer cells, and in combination there are early studies suggesting that the sequencing of a GVAX vaccine with listeria based vaccines may hold promise for pancreatic cancer. Also, I outlined in this talk some of the antibodies that are being explored, in particular CD40, C2A4 antibodies, as well as PD-1 and PD-L1 antibodies, and I think there's much more to be learned and to come in the coming months as well as years as to the role of these various immune therapies for pancreatic cancer. And then finally, CAR T cells as a personalized approach to applying immunotherapy to patients. So immunotherapies, and we've seen this now over the last couple of years, that immune therapy can have a dramatic effect against some cancers. We've seen this now in melanoma, as well as lung cancer, renal cancer, bladder cancer, and some other malignancies. And I think this is promising that we may be able to appreciate the same types of effects in pancreatic cancer. Certainly is true that only a fraction of patients are going to respond to any particular given immunotherapy. This appears that some cancers are more responsive to immunotherapy, and our understanding of how to improve immunotherapy for patients and for patients with for more patients and patients with pancreas cancer is steadily improving. We're continuing to try to find the biomarkers that are needed in order to advance pancreatic cancer. And which patients will respond to therapies is leading into an era of personalized medicine. I think we'll see more of this, not only in some of the other solid malignancies, but also in pancreatic cancer. And while there's no FDA-approved immune therapies at this time for pancreatic cancer, I think that the science with the animal models are really guiding now the clinical trials that are emerging and becoming available to patients and their physicians, and that's leading to the hope that pancreatic cancer can be a disease that is responsive to immunotherapy and that we can improve patient outcomes. So I think I'll end there, and looking forward to any comments and questions that others might have on this talk.
Great, thanks very much, Dr. Beatty, for that excellent presentation. Certainly, there's a great need for further research in pancreatic cancer treatment, given that it is a disease, I think the only major cancer type for which deaths are expected to rise in the near future. So definitely an urgent need for that. So we do have a bunch of questions that folks have submitted while speaking, and I'll go through them and get to as many of them as possible. But I'd like to remind everyone who's watching that you do have the ability to submit your question by typing in the Q&A box at the bottom of your screen. So the first question I have, Dr. Beatty, is you spoke of the role of the immune system both in suppressing tumors and in promoting tumors, and specifically the role of macrophages. And I was wondering if this is something that we see in other types of cancer as well, and what research is being done in those areas that might ultimately benefit pancreatic cancer patients.
So yeah, I think it's a common theme across nearly all cancers. For the most part, one of the major targets here are these myeloid cells. There's been quite a strong interest and how myeloid cells, these macrophages, impact the ability of T-cell based therapies to work. We certainly see macrophages in the vast majority of cancers, not just pancreatic cancer. In our animal models, we're seeing that strategies that inhibit the ability of these myeloid cells to infiltrate tumors or to be active can enhance the ability of T cells to be more efficacious. And so there are strategies, particularly looking at chemokine blockade with antibodies against CCL2, which I alluded to in the one of the earlier slides, that is being used as a way in which to get T cells to be more efficacious by allowing them to infiltrate into tumors, and because that's one of the barriers. We have a couple points of intervention that we need to think about. And first is how to get T cells activated and how these immune players can inhibit that process, as well as how do you get those T cells into tumors. So there's another barrier. And then once the T cells get into the tumors, how do we keep them to maintain their anti-tumor activity as opposed to becoming hypofunctional? And so each one of these steps, we're learning from our preclinical models that myeloid cells can be involved in those. And it's possible that perhaps not even just inhibiting them, that we might be able to redirect those myeloid cells so that they could help T cells to do the job that they're looking to do. So I think this is a common thread across all cancers, and so what we're learning in other cancers, we're going to be able to apply to pancreatic cancer.
That's great. When you're treating patients, how does the experience of being treated with an immunotherapy differ from chemotherapy? Now, you mentioned the cytokine storm, short-term, flu-like symptoms for about 30 minutes or an hour. Beyond that, what's the quality of life like in general?
Yeah, it depends. It depends on the type of therapy. I'll give you a couple examples. The CD40 therapy induces an immune activation in the patients. What that means is that there is a revving up of the immune system. There are cytokines and proteins that are being produced, and these cytokines and proteins can lead to flu-like symptoms, such that patients will develop chills and fever, as well as some rigors where they start to shake. And that's what's called a cytokine release syndrome that we see with some of our therapies. It certainly approached a finding that's been seen with CAR T-cell therapies and patients with leukemia, in which they'll develop this cytokine release syndrome as well. This effect is usually transient, though, and that's because of the fact that the immune system goes through multiple different steps. It's almost like a domino effect, that once you start it, you reach a certain point, you have this cytokine release syndrome, and then there's behind that a whole bunch of other things that the immune system is doing in order to engage in an effective immune response. Some of the other therapies, such as C2A4 antibodies, some of the concerns that we worry about in terms of immune-based therapies is these off-tumor but on-target effects. And what that means is that by engaging the immune system in a non-specific manner, which is what an anti-C2A4 antibody does, T cells could be alerted against normal tissues. And so some of the side effects that can be seen there are diarrhea because of impact of the immune system on the colon. Rarely, but sometimes seen, are perforations of the colon. One of the things that we've been worried about with CAR T cells that recognize specific proteins is that they could potentially target normal tissues because the antigens that we're using are not just expressed on the tumor but also on the normal tissues. So that means that if the protein of interest is expressed in the lung, that one could develop lung symptoms as well. So each one of these immune-based therapies has unique symptoms that could appear. It's also possible that the most that one will experience, such as with a vaccine that's administered under the skin, is a kind of swelling of that site of injection with some redness and maybe a little bit of pain that's temporary. So it really depends. I think in general, though, these are not the same types of effects where one can experience long-term nausea and vomiting, diarrhea, and usually fatigue are not major symptoms that are long-term with immunotherapy. And that's one of the reasons why physicians and patients have really reached out to this particular approach, because it does come with, overall, I would say, fewer side effects. But some side effects which are major that we need to be very cognizant of and follow closely.
I really liked during your presentation how you discussed learning something in the clinic and then taking it right back into the laboratory to kind of get to the root of it. And this integration of the laboratory and the clinic is an important thing, we feel, at the Cancer Research Institute, and we have an entire funding program devoted just to that. So you, as a physician scientist, are both in the clinic and in the laboratory. Can you speak just very briefly about what that experience is like and why it's very important to cancer research?
Yeah, when I started this pathway, I was initially going to just do research in the laboratory, and that was many years ago. And then I saw the value of seeing patients, understanding how they're experiencing and the therapies that we deliver in order to guide the questions that need to be addressed within the laboratory. And that's, once I saw that early during my training, I knew that was the direction that I wanted to take. And now it's almost an unbelievable experience to be able to see a therapy that's being administered to a patient, and now because of that one patient, you can learn so much. That they may have an immune response that you might not have expected. And you have the opportunity to watch that and be able to work with that patient to understand what's going on. And that really then guides exactly what one wants to do in the lab. back in the laboratory, because the goal here is to be as efficient as possible with our research so that we can continue to further treatment strategies for patients. And understanding how patients are responding, as opposed to even just our mouse models, is really important. And then adapting our mouse models to be able to recapitulate that disease process then allows us to be able to understand the mechanisms. Something we couldn't have done in that CD40 therapy treatment study is depleting T cells from the patient and such, but we were able to do in the animal models. And that's really informed and guided us along this pathway that we think macrophages can have a beneficial effect. So I think it's a rare opportunity to be able to have that experience, but to be in both places, in the clinic and the laboratory. But I think all researchers and investigators that are in the laboratory can certainly link together with clinicians, and they'd be happy to do that, to be able to have that crosstalk. And I think that's absolutely essential for bringing our treatments forward.
Well, thank you very much for that. Unfortunately, we are out of time today and are unable to get to the remainder of the questions. So I'd like to wrap up with just a few things. As a reminder, this webinar has been recorded and will be published either today or tomorrow or in the near future on the Cancer Research Institute website, and that's cancerresearch.org/webinars. We also have a library of past webinars there. All of them are free to download and view, so we encourage you to do that. Also, if you are a patient with pancreatic cancer or the caregiver of a patient with pancreatic cancer, and you'd like to learn more about immunotherapy in general, we do have a website called www.theanswertocancer.org, which is an online community for patients and caregivers that, as I said, features information on immunotherapy. We don't have yet a section specifically devoted to pancreatic cancer, but the information there will still be useful. And also, some of you had asked, where can folks find clinical trials for pancreatic cancer immunotherapies? On this website, we do have a clinical trial finder. It's a free service, and we'll connect you with a trial navigator who will help you find a trial for which you or your loved one may be eligible. I'd also like to let you know that in June, as part of our Cancer Immunotherapy Month, we will be hosting our first ever Ride to Conquer Cancer. It's a 2-day, 150-mile epic bike ride. It's not a race, as a fundraiser for the Cancer Research Institute. And if you're a rider or know someone who's a rider and would be interested in doing this, please encourage them to go to the ridetovictory.org/NY, and you can get more information and sign up there. I will be riding. I'm the team captain, so I hope you can join Team Cancer Research Institute. I'd love to see you out on the road with me. And that concludes today's webinar. I'd like to thank Dr. Beatty once again for joining us and giving us that very informative talk. And I look forward to seeing you all at the next webinar. And in the meantime, if you're in the United States and you celebrate Thanksgiving, have a happy one. Thank you all. Bye-bye.